mentioned that we are looking under the contact diseases, under communicable diseases in this session. Okay. Now, the first thing for scabies is that it is basically a parasitic infection that affects the skin that has a very unique kind of distribution, and it's caused by this mite that is called Scabies scabies. So there are different kinds of mites that are there, but this one is normally regarded as the itch mite or Scabies scabies. So just look at the historical perspective. The disease scabies has been there for quite some time, and it has been described since the Greek and the Roman times, where Celsus and the rest actually described some diseases that had the same kind of signs and symptoms as scabies. Around 1577, there was a first suggestion that this disease or scabies actually was caused by a parasite, and this was mostly described by Girolamo on his book or on his work that it was regarded as De Morbis Cutaneae, which basically translates to on diseases of the skin. So later on, around 1687, this is the first time actually that the mite itself or the parasite was actually seen or identified directly by an observation through a microscope by the scientist Bonomo. So this actually was a very important time, because now we're able to directly link the disease to the agent that is actually causing it, so through the observation. So other accounts in history, such as like Napoleon was said to actually have suffered from the itch his entire life, and actually a lot of people think that he had scabies. For time immemorial, like around the old times, Bonomo, who is one of the Dutch scientists we just described earlier, he started using sulfur as a way of treating these itch, and it was found to actually be effective. But this sulfur had to be given for a period of time, even after the itch stopped, so that it could actually also work on the mite that just hatched. So basically, from this history, we can see that scabies is a disease that has been described since a very long time, and we have improved in the amount of knowledge that we have acquired on its transmission, on its causative agent, on the mode of treatment, and so on. So we are no longer, for example, using sulfur. We have moved from that, and we are using better kind of treatment. In terms of distribution, basically, if you look at this epidemiological pattern, we can see that in Africa, and especially in the Americas, that's where we have plenty of cases. So in Africa, we have cases, some medium level of prevalence around Kenya, basically East Africa, Egypt as well, some parts of West Africa, and also in the Americas, in the areas of Argentina, Brazil, having higher prevalence. However, Australia is the one that is known to actually have the highest prevalence of scabies. Okay. Now, scabies, as you've seen, is common in some parts of Africa, and specifically the rural parts of Africa. And scabies is endemic in many areas that are basically poor areas in the tropical region, and with a prevalence of around 5 to 10, affecting mostly children. So basically, it has a recurrent infestation, and infection symptoms are basically more prevalent in children than in adults. So for us to understand the disease, we also have basically to understand the causative agent, or basically the parasite in this case, which is the mite. So the mite has certain features that enable it to cause this sort of disease, or the burrowing itself. So first of all, it has a very small size, and we'll see how big the female mite is. So it has a small size and flattened body, and this enables it to move around and burrow through the skin. On top of that, it has some very interesting features around the mouth parts, which is called chericai. And this area basically is adapted, and I'm trying to show you with a highlighter here. This part is basically adapted for piercing through or cutting through the skin, and then cutting, so that now we can break it open and enable the mite to actually burrow through. On top of that, it has very powerful legs that enable to push it and pull itself through the burrowed skin, so that it can continue to move in towards the skin itself. These features on top of others, like so we have seen the structure here, and the way the female mite is quite small in terms of size. It's around 0.3 to 0.4 millimeters long. This enables it to move quite easily. And some of the features that we've just talked about enables it to basically cut through the skin very fast. So it can burrow through the skin within minutes, basically, and then start moving down there. So once it moves along the skin, it is able to lay its eggs, and it has other features like some lubricants that it produces to enable it to reduce things like friction as it is burrowing through or as it is moving across the burrow that it has just done. So there's so many other features that enable that mite to actually burrow through, but those are some of them that I think are important for us to know. Now, once it is, once the mite actually attaches itself, there are certain ways in which we can actually get this mite onto the surface of our skin. So infection basically, or infestation is basically through close contact. So if somebody's been in very close contact with another who is actually infested, then they can get it, or sharing of some items or like things like bed, like among children who are sleeping around together. People who have basically prolonged contact in adults, mostly seen frequently in people who have sex with each other, basically because of the contact that they have. So that is basically how we end up spreading. So if we also like sharing things like linen that we are using like in the bed or something, so that can also be an area of transmission. So however, scabies is not a very contagious disease, and basically rarely would it be transmitted if people have very good hygiene status, basically. So scabies is caused by small arthropods, which are called Sarcoptes scabiei, and we know that. So by whichever means that we have talked about, whether it is close contact, whether it is sharing of items or bed, linen, or other things like that, the ultimate event is that you have the female mite itself. So it has to be the female mite that burrows through. So like from this point, the female mite burrows through and gets deep into under the skin, okay? So always the burrowing happens at the superficial layer, okay? And never below that, because now once it goes below that, then there will be other consequences, okay? So the skin selects, the skin that is selected for burrowing is always very thin and wrinkled, and that actually explains why scabies has a characteristic feature of rashes in certain parts of the body. Okay, so once it burrows and gets to the point that it wants, the adult female, for example, now it will hatch the eggs and also produce things like feces. And by the way, these are the things that now elicit immune reaction and have the itchiness. So after 4 to 5 days, the eggs that have been hatched, the eggs that have been produced by the female will actually hatch, and then they will leave this tunnel, then go to another area and bury themselves in the skin. Okay, and but they do not make the burrows. So if they have to actually hatch, and then now we have them developing into an adult female for them to actually burrow through. So as you can see from this, so you have the egg. After a few days, it changes its morphology from larva to nymph, and then now it becomes an adult after a couple of days to weeks. So once it's in the adult female, then it burrows through, then produces other eggs, and so on. So basically, that's the cycle that is there. Kindly note, once the egg hatches into larvae and then develops into nymph, and then we have an adult female, the male will obviously mate and then now leave the female basically pregnant. And then now the female is the one that now will burrow through and then produce the eggs and all that. The male normally dies shortly after that, doesn't need to burrow through and go and produce eggs. So basically, once the adult male impregnates the female, then that's normally it. Okay. So the clinical picture, basically, there is intense itching. I think we talked about that. Normally, especially at night, because the burrowing normally will be at night when somebody is you see, at night, normally we're in a stationary state. So that gives time for the mite to start burrowing. Movement reduces the chances of it to start burrowing. So itching leads to scratching, and then we might have secondary infection, which actually is almost inevitable. So in cases of immunosuppression, then we might have extensive kind of infestation. So the types of scabies that we have the classical type, which we have just described, which is what we normally see in most people. So they will have these rashes in different parts of the body, like the elbow, fingers, waistline, genitals, and all that. But no, the severe form is what we call the crusted scabies or Norwegian scabies. This one is highly contagious, and basically it's often seen in individuals with weakened immunity. So as you can see, this one, this person here has basically what we call the Norwegian scabies. So the other one is the incognito scabies. So normally this one will basically be seen when treatment has been started. So it has masked the signs and symptoms that we will actually see. So we have said you have characteristic rash. So the rash basically can be seen in certain parts of the body, like the axilla area, the nipple area, belt line, around the umbilicus, thighs, and buttocks. So those are basically the classical areas that we might find. But not to say that we cannot find them in other places, we can, but these are the places we commonly see them. So the clinical picture, I think I'll just say, but just to reiterate, the classical pruritus, this is the most predominant symptoms, intense itching. So we have rash that is there, and then we have this burrow track. So this shows the track that the mite has passed. And then we might have other secondary infections. So diagnosis is quite simple. You can use clinical features, basically the rashes you have seen in the classical areas, but observation can also be done to actually see the burrow. So a dermoscopy is done sometimes to actually see, but in most cases, it will be just sufficient just to look at the characteristic feature of the rashes. So the treatment of choice is benzyl benzoate, which is given and should be applied after a warm bath normally, and then it is repeated after 24 hours. However, other medications like permethrin cream, even soap is used, permethrin-based soaps, but also ivermectin can also be really useful. So prevention is quite simple, basically regular bath, washing clothes very well, sometimes even with warm water, frequent use of soap, and preferably soap that is based on permethrin-based. Health education on hygiene status, issues of bathing and all that. And when you're doing the treatment, you should do it to the whole family. Okay. So thank you so much for listening.